Yeah, hey everyone, my name is Andrew Bzowyckyj, and I'm a senior scientific director and learning consultant with the National Kidney Foundation. Yeah, so the takeaways for this presentation were to think about these and other signals. We picked three, but I mean, there's a lot of different signals that are available. Again, leveraging existing electronic health record. Kind of answering the other question about, what can pharmacists do? Kind of looking for these testings and recommending these testings if it's part of your scope or if it's clinically indicated. So thinking about kind of what parts of the puzzle you might be missing. In terms of earlier CKM risk stratification, I think hopefully everyone has been convinced to move beyond A1C and diabetes care. This is something that's really taken hold in the standards of care for the last 5 years. And they've also been in the clinical endocrinology recommendations for even longer than that. But we know A1C is important, but we really need to move beyond that to think about CKM, cardiovascular kidney metabolic risk. What I would recommend for pharmacists is help close that UACR testing gap, especially in diabetes, because there is a HEDIS measure related with this, but then also with hypertension. Again, it's part of the recommendation, the guideline recommendations now. There's things that we can do about the UACR to help lower that CKM risk, and so it is a quantifiable measure that we can impact. And we know that the lower we can get that UACR, the lower we are lowering patients' cardiovascular and cardio-kidney risk. And so whether that be through protocols, standing orders, recommendations, anything you can do to kind of influence that UACR testing in high-risk individuals. So we're not testing everyone, but we know folks with diabetes, hypertension, heart failure, potentially obesity, high-risk candidates for CKD. And then on top of that, so being able to interpret these results. So that was a big takeaway from the presentation was how do you use these results and translate them into actionable steps and education pearls for our patients. So again, my co-presenter, Dr. Turkson, presented really well on HFpEF versus HFrEF. And so HFpEF is like the pump. It's just really stiff. It's getting its job done, but it's kind of stiff and can lead to certain symptoms. HFrEF, you have this pump, but it's just not quite pumping as effectively as it could or should. Thinking about albuminuria, thinking about systemic inflammation. How would you describe that to a patient? And how does that work for them to act upon that information? And then lastly, helping connect these dots for patients to encourage healthy behaviors and then reinforce that value of guideline recommended medications. So I'm a strong believer in Simon Sinek's start with why principle. So really, like, unless I know why you want me to do something, I'm less inclined to do it. So really working with our patients to show them the why, tell them the why, and likely to get some more patient engagement following that principle. Yeah, and admittedly, this one's a bit more nebulous, as it's not really a routine test. It is used a lot in certain inflammatory conditions, so lupus, rheumatoid arthritis, different conditions where there might be an inflammatory component. When we put this in our presentation, so this was a collaboration between ADCES, NKF, and PCNA, our three organizations. And we knew there'd be a lot at the conference about obesity. There'd be a lot about a metabolic associated steatotic liver disease. We knew there'd be quite a bit on diabetes, of course. And so we are trying to think of something different to kind of present that would be a little different from the other programs. So this is where this high sensitivity C-reactive protein came in. So we know that an hsCRP above 2 has been considered a marker of increased cardiovascular risk in several iterations of the previous guidelines. So it's been around, even back with the pooled cohort equation, it was always one of those risk magnifiers to consider. I referenced clinically ambiguous situations above. So if someone has like an intermediate 10-year, an indeterminate 10-year risk score, that's something to kind of look at. Or if you're trying to interpret the impact of a patient's kind of separate inflammatory condition on their CKM risk. So for example, maybe they have rheumatoid arthritis. How does that affect their cardiovascular risk? How does that disease kind of play in? That's where kind of hsCRP could be considered. But also thinking about patients who are ambivalent about their risk. So I've had a lot of patients where we've had the statin conversation or we've had the conversations about cardiovascular risk. Smoking cessation is another big one. And really kind of knowing like, well, I know it's good for my health, but why? Like, why do I really need that? Like, why me? And so this could be just another data point for people that love data to kind of think about, what's happening in my body and how can I, further lower my risk in a measurable way. So just some ways to use this tool. Again, it's not recommended in everyone. It's kind of it's a risk magnifier for folks where you're trying to kind of navigate some of these ambiguous situations. And then from the CKM paradigm side, Many of these medicines also provide anti-inflammatory effects. So we know the GLP-1 receptor agonists, the SGLT2 inhibitors, the colchicine, even like metformin has anti-inflammatory effects. So they're all kind of nipping away a little bit at that systemic inflammation. And so this could be good to incorporate into your medication education repertoire. So, you described there's this systemic inflammation as like the slow burn that's coming with these CKM conditions. And so, why might one medicine benefit? You take one medicine, let's say SGLT2 inhibitors, for example. They were originally designed for diabetes, but now they're also helpful for heart failure and they're helpful for CKD. And so for a patient, that might be confusing. And so kind of systemic inflammation is one of those things that's tying these disease states together, driven by albuminuria, driven by all of these other factors. So it could be kind of a good way to frame it to the patient so that they're understanding a little bit more as to how these medicines work, as opposed to, just thinking it's voodoo or magic. Provides a little bit more evidence to that conversation.